at ASH last year, there was a presentation about a long-term follow-up of patients with relapsed refractory mantle cell lymphoma on Ibrutinib. And this was the one in which three clinical trials were put together. Patients were followed up. It was very good design study. It's 3 years of follow-up. The data shows that in those patients that achieve complete response, as Ibrutinib as a first-line therapy after relapse, so as a first relapse, at the first relapse, so those patients do well. Also, what we learned from that study is in patients with relapsed refractory mantle cell lymphoma, if you use your Ibrutinib at first relapse, it's going to be better than second, third, or late, or multiple relapses. And that is very important because that is helping us to understand that. So here we have a new drug with a new mechanism of action that is different than chemotherapy, and the earlier you use during the relapse setting, the better the patients are going to do. And the other measures about the clinical trial is now we are seeing 3 years follow-up. Also, what we are seeing with long-term follow-up is that most of the side effects associated with Ibrutinib, you are going to see them during the first year. And then since that the patient's body gets used to, and then the patients are able to continue with treatment. So, and I think it is putting this in perspective when we are seeing any targeted agent. So we all get excited, and we get that. So we get excited about great overall response rate, great complete response. But I think it's important to let the data to mature 1, 2, 3 years, and then have what is the real progression-free survival. Are we impacting overall survival with a good quality of life? Remember, mantle cell lymphoma is elderly population, and that's what I always tell my students. So we are dealing with elderly population. Geriatric assessment is important, and then based on that, so you make a decision. But we need to be careful because we don't want to use a complete response, but then the patient is going to be affected in his or her quality of life.
You know, what's really nice about the long-term safety data with Ibrutinib is we're not seeing anything radically new that's coming up. You know, we knew that the bruising, the contusions, we knew the atrial fibrillation, you know, we had a good feel for this really from the pivotal frontline phase 2 trial. You could argue that maybe we're seeing a little bit more in the way of the atrial fibrillation events, but I'm not seeing anything that has me overwhelmingly concerned. I think that it is important to keep in mind that Ibrutinib can be associated with cytopenias, particularly with longer use. And what we've seen at our center has mainly been thrombocytopenia, and that can make it a little bit challenging at times to dose the Ibrutinib. It may require dose reductions and other things that you know, we have to address. The other thing with Ibrutinib is recognizing the risk of infection. It seems like it's an earlier event for most patients, meaning within the first 6 months or so of starting therapy. But you know, you have to be vigilant, and I'll just leave it at that there can be infections that are atypical that you wouldn't otherwise expect, and so you just have to keep that in the back of your mind. And when I say atypical infections, you may see things like CMV, you may see things like PJP, you may see these weird infections that you wouldn't otherwise have expected. I don't think that that's, I don't want to belabor that. I mean, these are patients who have seen prior chemotherapy, whose immune systems may not be entirely normal before going into therapy. Not on top of that, you know, having mantle cell lymphoma, which may also, like CLL, come with IL-10 autocrine secretion, autocrine production. That may also further suppress immune function. There's a variety of things that are influencing possibly this infection data point, but it's just something important that I wanted to make sure I stress.